sounds like polypharmacy is just a natural issue when it comes to treating chronic pain patients. You know, Charles, being the token neurologist here, I'm going to pick on you just a little bit. Sorry about that. You know, when you look in the label for these neuropathic agents, for these anticonvulsants, sometimes they say postherpetic neuralgia, some talk about diabetic neuropathy. Does the label really affect the way clinicians practice out there? And do you think that any of these agents are better suited for one disease state, or do you think clinicians should rotate through each of them and try to find what's best for the patient?
I think that it's a really important question, and I don't know if I can answer it the way you want me to. I think that it would be not scientifically sound to say that every neuropathic pain state is the same. So painful idiopathic neuropathy is not the same mechanism in all likelihood than chemotherapy-induced neuropathy, which is one of the fastest growing segments of painful neuropathy. Postherpetic neuralgia is both a peripheral and central mechanistically based neuropathic disorder. Trigeminal neuralgia, totally different animal, and painful diabetic neuropathy linked to the metabolic issues of diabetes itself. So it would be unfair to say that you could extrapolate data from one set to another, and I think studies show that you get different outcomes in people. On the other hand, the rules, so-called rules of the FDA, are such that once a product is on the market for a specific labeled indication or indications, so let's say pregabalin has postherpetic neuralgia, diabetic neuropathy, fibromyalgia, other conditions, spinal cord injury-related pain now. That doesn't mean that it's more effective than carbamazepine, which only has an indication for trigeminal neuralgia, and because that's not what the FDA is analyzing. So I think many seasoned clinicians have developed a sense, based upon the review of the total literature and FDA approval, to kind of know which medicines work in which settings. FDA indication is great because it gives you a sense of where the drug has been studied, but it does take certain experience levels, and also keeping in mind that no two neuropathic pain states are the same. And I'm sorry if that didn't answer your question directly, but it just, again, caution, guidance, know the literature, and go from there.
Much appreciated. And my colleagues understand that Charles has certainly been a key opinion leader in the help of developing guidelines for the treatment of neuropathic pain, and clearly an educator in this area.
But one point about that, most of those guidelines were based upon studies of painful diabetic neuropathy and postherpetic neuralgia. So we all believe in evidence-based guidelines, right?
Of course.
But how do you extrapolate the evidence from two well-studied conditions to chemotherapy-induced neuropathy, to radiation-induced painful neuropathy? How do you do that?
Sympathetically mediated pain.
Exactly. There is no. When going back to payers, when payer says you can't use that because it's not FDA approved. Well, what drug is FDA approved for MS-related neuropathic pain? And yet, in a study that was published in Pain by Yale neurologists, about 50%, 60% of people with MS regularly experience pain. And so every drug is off-label. And is the payer saying nothing should be prescribed for that person? So it goes back to our clinical judgment and the fact that the FDA allows medications to be used off-label when we've considered what data there is to support that.
But I think it's helpful to know what the guidelines are to have a basis for initiating treatment. So let's think about